Now give it a try.
Okay, try it now.
I think we're.
All right, well, thank you everybody for coming today. It's my special pleasure to bring you Rose Zulliger. So she's a senior malaria technical advisor contract with USAID. So prior to joining USAID in 2021, Rose spent 6 years in Mozambique with CDC, primarily working on malaria until she became extensively involved in the Mozambique response to COVID. So Rose has published more than 40 quantitative, qualitative, and cost effectiveness articles, along with more books and book chapters. She's lived in Mozambique, South Africa, Bolivia, and speaks English, Portuguese, and Spanish. Today, Rose will speak a little bit more about her career trajectory and her current work with the U.S. President's Malaria Initiative, and talk about the overall field of global public health. So welcome, Rose.
Thanks, Tony. And I guess before I begin, I'll say in my mind, I was envisioning like a room of undergrads. And so we'll kind of pivot a little bit as we go in terms of what, extent this message is relevant to our interests. And we can go a little bit more into more technical topics too, if it becomes of interest. But as Tony mentioned, I'm going to talk a little bit about sort of one potential avenue that you can take with a global health career. More specifically, I'm going to talk a little bit about my personal career trajectory, not because it's so interesting, but I think sometimes it's not always understood by individuals that are studying public health. I'll provide a really quick snapshot about what the US global health investments are looking like. And I'll particularly talk about the President's Malaria Initiative, where I'll describe what I do and then provide one example of an area of work that I lead for the President's Malaria Initiative called subnational stratification and tailoring. So, who can tell me what's on the top left?
Baltimore Orioles.
Yeah, thank you. Thanks. So, my career trajectory in public health started with the Baltimore Orioles. I was in, when I was in high school, I felt like I wanted to go and do work in Africa. But for me, I thought that meant international relations. So I went to Johns Hopkins University, where I originally was studying international relations. Now, about a week into my macroeconomics class, I realized that maybe that wasn't the best fit for me. And so I quickly pivoted and was able to get into public health program, where I was able to take kind of a wide array of classes. Now, by the time I got to kind of my senior year in college, I was like, well, this is all really great. What do I do now? I wanted to go abroad. I wanted to try and serve, but didn't quite know what that could look like. So what's a really good way to get abroad if you have an undergraduate degree and want to do health work for the US government? Peace Corps. There we go. Here we go. Here's your Peace Corps little prize there. There's a, so Peace Corps is a really great entryway to learn and get some really practical experience. So I went from the Orioles to the Lions. I ended up in South Africa, where I was assigned to work with a community health worker organization. I was in a part of the country that had 20% antenatal prevalence of HIV, which meant that 1 of every 5 women who showed up at, pregnant had HIV at the time. As you can imagine, in the early 2000s, that meant that there were a lot of orphans and there were a lot of people in need of home-based care. That was my first real exposure to some of the really critical challenges that are faced within the global health world, but also not unique to global health. The community health workers are an imperative, but also a challenging aspect of health around the world. So I was there helping to coordinate the services that community health workers were providing for orphans and vulnerable children in my community. But towards the end of my service, I got connected with a local researcher, and he was interested in understanding the quality of home-based care services provided by community health workers. Shocker, all the same problems that I was seeing with this organization in front of me have been documented in literature for decades. They've been documented all over the world. I know that there's a strong community health program here, and a lot of the same problems that you guys see facing community health workers in Montana are faced by community health workers in Mozambique, and faced for decades. Inadequate supervision, inadequate career trajectories, so on and so forth. So for me, that was a bit of a wake-up call that why do we know there are these problems? We've been documenting them forever, but we're not figuring out necessarily how to address them or how to put it into practice. And that led to me to kind of identify what in many ways has influenced all my career decision-making, which is figuring out how do you think about these kind of what could be academic questions, but really think about the real world implementation. So what should we do to help community health workers? And how do you do it in a way that's scalable? How do you do it in a way that you can monitor if it's working? And if it is working, scale it up. If it's not, figure out how to make it better. So I realized, unfortunately, that meant I needed more graduate school. That was never a part of my plan. I didn't think that I would go to grad school, but I realized that I had a lot to learn, especially in terms of how to actually go about designing interventions to strengthen the quality of work that was being provided. But I wasn't quite ready to go back to the United States. What's the top right? Anyone?
This time.
I mean, it looks like a nice place, right? So this is Cape Town, South Africa. So I decided to fly kind of across the country I had been in the northeastern part of South Africa. I flew to the southwestern part of South Africa, where I did my master's in public health at the University of Cape Town. Now, it was a bit of a public health dream for me as someone in global health, because I got to do things all day, like helping to rapidly initiate pregnant women onto HIV, onto antiretroviral therapy during the day. And then on the weekends, we would go hiking and drink lovely wine. So it's quite a nice place. If you haven't been to Cape Town and the world ever brings you there, it's a really important place to do work, but also a lovely place to live. So as I got towards the end of my MPH, I was able to be involved in a number of different really important implementation science projects. So you can see this bottom left here, it's the tutu tester. At the time, kind of globally, there had been a practice where if you get an HIV positive diagnosis today, we're going to take you through an extensive treatment literacy program before we start you on antiretrovirals. It's a really big diagnosis, it's really important. But if you are a pregnant woman, every single week that you are not on treatment increases the likelihood that you will transmit HIV from yourself to your infant. So our project was one of the first projects in the world to actually initiate pregnant women onto antiretrovirals the same day as their diagnosis. So what we were able to do was to take a problem, develop an intervention to try and address it, and document its effectiveness, both through qualitative but also quantitative work, showing ultimately a pretty important reduction in mother-to-child transmission of HIV. So this was one of my favorite projects. I then realized that my parents were getting a little frustrated that I was still living in South Africa 4 years later, and so it was time for me to come back. And I also realized that I hadn't gotten all the training that I wanted, especially related to behavioral sciences and thinking about really strategic design of those interventions. This person absolutely agrees. And so I came back to actually Baltimore, where I did my PhD at Johns Hopkins in health, behavior, and society. For me, it was always an opportunity to learn specific things. It wasn't that I was forging forth an academic career. I knew that I had specific skills and specific experiences that I wanted to gain from my PhD, and was able to connect with a really great project that was PEPFAR funded, so US government funded, in the Dominican Republic, helping female sex workers living with HIV to access and adhere to HIV services. Again, from the notion that their accessing and adhering to services was imperative for their own health, but also would have important implications in terms of the onward transmission of HIV. So that was a great learning experience, and I think I successfully ticked many of the boxes of spending time with my family as much as possible before I realized that it was time for me to go abroad again. And so that led me to Mozambique. So I figured if Cape Town is challenging, no one was going to go to Mozambique, so I gave that one away. But that is, in fact, Maputo, Mozambique. And I'll talk a little bit more about Mozambique later in the presentation. But just to say that when I first went there, it was as a fellow with the CDC. And then I transitioned into a direct hire position where I was working with the President's Malaria Initiative, which will be the focus of most of my conversation. So you might be sitting here thinking, why on earth did she tell me this? But I just remember being an undergrad and not really knowing what are some of the different things that I could do when I finished school. And so you'll see at the end, I'm not going to go through them, but I have included a few different slides with links to things about, for example, the Peace Corps, USAID, CDC, and fellowships and different internships that exist within them. But no test on that, I promise. And then lastly, you might be thinking, well, why on earth is this woman who spent a lot of time living in Southern Africa standing in the room with us here in Missoula? And that takes me to, I guess, my last picture, which is a
Grizzly bear.
there we go. Well done. I've been learning about my bears. So after many years of graciously following me, we have now followed my husband's career here to Missoula, where he's with U.S. Fish and Wildlife with the Grizzly Bear Recovery Program. So I'm learning a lot about flights from here to the African continent and Asian continent, many pros and cons. So I'm going to really briefly now just provide a bit of a snapshot, because at least for me, this was always a black box. Like, what does the US government actually do abroad? And so you can see here that it does a lot of different things in a lot of different ways. So first, the US government is a massive global donor in global health. So that's why you might have noticed throughout my career trajectory, there was a lot of US government. Well, that's because our government in just, for example, fiscal year 2022 contributed over $12 billion towards global health. That sounds like a lot. It is a lot. Our government also contributed over $700 billion to the Department of Defense. So while we are important donors for health, we are important kind of contributors to many global efforts, health being one important avenue. And we do that through a number of different ways. So I'm not going to go through this in great detail. If you want to learn more about it, there's a nice link provided at the bottom of the slide. But you can see, for example, that we have a development agency, which is USAID. So if you heard that there was a hurricane somewhere and we are out there building schools and tents, that's USAID. If you've heard about us doing any variety of different development related things, be they education, health, governance, for example, those are all falling under USAID. And the initiative that I work for sits within USAID, the President's Malaria Initiative. We also, has anyone heard of PEPFAR before? This is so interesting for me as someone who's worked mostly in global health, like PEPFAR, like for better or for worse, can't not hear about it. So PEPFAR is the US President's emergency plan for AIDS relief. It's been over $110 billion since the early 2000s that has literally saved tens of millions of lives. The US government is integrally involved in keeping people HIV free and helping them to stay alive if they are HIV infected. And almost all of that money is through PEPFAR. And then there are a number of other ways in which we support. So for example, Peace Corps is on there, and HHS, including CDC. CDC in particular has a really important footprint within PEPFAR, within those HIV-related services. Surprising now that Patrick very nicely gave me a clicker I'm not using. And just, circling here that these are the 5 different institutions that thus far have touched my career and that I've worked for. And many people that you'll find within global health, whether they are directly working for them, they're not directly working for them, they're working on a project that receives at least some sort of funding from one of these agencies. So with that in mind, let's talk about malaria. Who in here does any work or has any kind of interest in malaria? I promise I won't be offended.
Interest.
Okay, thank you for interest. I'll take what we can get. And so recognizing that people have really different backgrounds, please jump in if anything I'm saying doesn't make sense. I do my best to not use acronyms, but all of us are so inundated with acronyms and kind of assumptions of shared understanding that I'm sure I will say things that don't make sense. Stop me. This is meant to be interactive. So what you can see right here, this is from the 2023 World Malaria Report. This is a big report that comes out every year from the World Health Organization, showing the global trends in malaria case incidence. So that's what's shown in blue here. It's the incidence per 1,000 population at risk, and the malaria deaths per 100,000 shown in red from 2000 until 2022. What do you see? How's it looking?
Getting better,
Getting better.
but leveled off.
Yeah, we definitely, the COVID times were not great for any global health or for any health, let's be honest. And we saw some loss in the gains in malaria. I'll say malaria fared better than, for example, immunization coverage. Immunization coverage has had, I think it's about a 30-year reduction in gains due to COVID. So on the whole, pretty good trajectory, but not overwhelming. Here we are. So that was incidence. This is the overall burden, number of malaria cases. So you can see in blue, for example, in 2019, there were 229 million cases of malaria in the world. And the vast majority of those shown in green were on the African continent. How's this one looking? Better or worse? I'll go back. Which one would you rather see? This is kind of a general slow downward trend, right? How are you looking here? We went from 238 million cases to 229 million cases in 20 years.
Not great.
Not great. Why are we seeing a reduction in incidence when our burden is staying about the same? Is there anything else that might be happening? Denominator is increasing. That's a huge part of it, right? The global population goes up. So even though we're having less malaria, more and more people are in these areas. And so we are seeing an increase in burden, or at least a stagnation in our gains. There's another important stagnation that's happened. So this is the funding for malaria control that's happened. So this is showing from 2000 to 2021. So really important improvements from 2000 to 2009-ish, right? We start to see going from about $500 million in 2000, almost all of which were from the governments of endemic countries, shown in pink, to the introduction of the Global Fund, really important donor in the global malaria, HIV, tuberculosis space. US government is one of the largest donors directly to the Global Fund. And really important introduction of that USA bilateral, shown in what is a really unattractive to me, brownish, yellowish color. So pretty important gains, right? From 2000 to 2009. How are things looking since 2009? About the same, right? So we're saying, okay, UK government's no longer giving as much, a little bit more. But we are not seeing any increase in real terms in terms of funding for malaria, despite the fact that cases are going up and actually our interventions are getting more expensive. Interventions are getting more expensive for a lot of different reasons, one of which is that the insecticides that we use, we're getting resistance to, so we have to use more expensive insecticides. The treatments that we use, we're developing resistance to, we have to use more expensive treatments. So more cases are about the same cases, more expensive interventions, same amount of money. It's kind of where we find ourselves in a global malaria context. Well, that seems kind of grim. If you start to think about what are we as the US government doing in the malaria space, you can start to feel a little bit better. So the US government there's been a lot of different efforts to look at sort of what has been the impact of the President's Malaria Initiative. That was that USA bilateral we saw on the other slide. We've helped save 7.6 million lives through the President's Malaria Initiative and prevented 1.5 billion cases of malaria. And that's all been since 2006 when the initiative began. So about $8 billion in that time period, leading to about 1.5 billion malaria cases averted. And to just give you a sense of it, we have in any given year about $750 million that the US government is contributing to the President's Malaria Initiative. Those dollars you can see kind of slowly growing up and then just staying nice and steady here from about, like 2009 onwards, more or less the same amount of money every year And that is to support work in 27 countries. Those 27 countries are shown in blue, primarily in sub-Saharan Africa, but also a footprint within the Mekong, greater Mekong subregion, which includes Cambodia, Myanmar, a bit of work in Laos and Thailand as well. So what is the President's Malaria Initiative? Anybody ever heard of it? If you haven't heard of PEPFAR, I'm sure you haven't heard of President's Malaria Initiative, but now you have. We call it PMI. And so PMI really is the way that primarily the US government is supporting malaria work around the world. And it has three main kind of objectives. One is to reduce deaths. This is the most recent strategy. We're hoping to reduce deaths by 33%, reduce the burden of malaria, so illness, by 40%. But we also want to get towards malaria elimination. And here's a fun little fact, and you get to choose if you want a bracelet or a key ring. Why is the CDC located in Atlanta?
Malaria control domestically early on.
Exactly. It is the only federal agency located outside of DC, and it's located there because that was kind of the real central where we had some of the highest malaria transmission in the United States. We only eliminated malaria in the 1950s here. So important global progress has been made. We want to continue to make that progress in a number of countries, especially within the Americas, China, a number of Asian countries, and even some African countries are making advancements towards elimination. Where we want to get, obviously we have a ways to go. So we are hoping to accelerate towards elimination. I'll let you decide later if you want the bracelet or the keychain. But yeah, there's your fun fact for the day.
Can I ask about elimination now, or are you gonna get to that?
No, I'm not, so please go ahead.
So would you just eliminate the vectors, or how does that happen?
Yeah, great question. So malaria is fascinating for the exact reason that you mentioned, right? It's not just human behavior that we're interested in. We have a vector that we have to take in mind. We still have the malaria vector, so Anopheles here in the United States. There are like, I think it's about 50 or so competent malaria vectors. You knock out one, what we start to see is one of the other local vectors just increases in its population size. So for example, one of the most prominent vectors within a number of the countries where PMI works is Anopheles funestus. A lot of the interventions that we do, like indoor spraying, so we'll come inside homes and we'll spray homes with insecticide. We also give people insecticide treated nets. That's really great for vectors that bite in the night and that bite inside homes. They don't all. So there are plenty of mosquitoes, as we all know, that will happily bite you when you're outside. They'll bite you during the day. So what we tend to see is you knock out one, so funestus starts, so you introduce indoor residual spraying in an area, you start to see funestus drop. Well, Gambii doesn't mind it. So Gambii goes up. So we're not trying to get rid of the vector in general. There's certain situations. So for example, islands are wonderful little test cases for things where you start to see a lot of interest in things like genetically modified mosquitoes. But when you think about the African continent, where there are so many different vectors, anytime you're modifying them in one way or another, there's some disadvantage to that allows some of the other alternative vectors to kind of grow in abundance. So we are not trying to change the vector, but if the same little happily, funestus that's flying around is not finding anyone that has malaria, it's not going to be able to transmit malaria. It's just a lot of our big approaches are related, for example, to chemoprevention. We might, for example, one of the big investments has been seasonal malaria chemoprevention. We will go house to house in communities, giving every single child between the ages of 6 to 59 months an antimalarial. Knocks the parasite out of them, provides some protective effect. They are also important carriers for kind of their overall family. By giving them SMC, so seasonal malaria chemoprevention, we start to drive down infection because it's less likely that we're not getting rid of that mosquito, but that mosquito is not going to be transmitting malaria onwards. So a big push of what we do is trying to find that right balance between vector control and chemoprevention, And then also noting that case management has an important role as well, because if you're infected and you get treatment, then you're not, when that mosquito comes to your home, it's not then going to carry malaria onto your neighbor. So we also want you to be getting tested and treated as quickly as possible. So it's kind of a multi-pronged approach, and I'll talk a little bit more about that in particular.
All right, thanks.
I really know nothing about malaria.
Oh, that's
So
okay.
can mosquitoes not transmit malaria to each other?
So no, like they wouldn't, the answer is no. So what they are doing is they will carry the parasite within their gut. They then, as they're biting someone else, but they're not having kind of gut exchanges. That makes sense.
Okay.
That's a really terrible explanation, but the
Yeah,
answer
that
is
makes
no.
sense. Okay.
They're getting it from
Yeah.
another person. So
Yeah.
even, for example, a lot of the malaria vectors aren't necessarily only biting humans. They're also biting cows. They're also biting, the goats in the home. So there is even interest, for example, in if we give that goat ivermectin, which is an important drug for not anyone do NTD work here. Ivermectin is like a really critical drug in terms of global health progress, especially with NTDs. That can then actually have an impact on the life expectancy of that mosquito. So we're able to use even animals potentially to help reduce the likelihood that the mosquito is going to live, procreate, and then also, the likelihood of onward infection. Does that make sense? Yeah. You look unsure. I want to hear it.
Oh, no, I was just one, oh, sorry.
No, I'd happily hear
Yeah.
you too. There was like a timid, partial hand up.
Yeah, so I just kind of have a little question related to the number of deaths caused by malaria. Is any of that contributed to like the different types of strains of malaria that are going around? Because I know Plasmodium falciparum is definitely more deadly than like Plasmodium ovale or Plasmodium malariae.
Look at you. You said you didn't know about malaria. Gold star. Absolutely. So falciparum there's much higher morbidity and mortality associated with
Yeah.
falciparum. It is also the dominant parasite within Africa.
Yeah.
So you'll see more vivax, which does have morbidity. It's harder to treat. You see more of that kind of within Ethiopia and within Southeast Asia. But in terms of what's driving malaria mortality around the world, it's absolutely Plasmodium falciparum.
Okay.
Ovale and Knowlesi also become important as you think about eradication. And there's a lot of global dialogue about, can you consider malaria to be eliminated if you still have ovale? But right now, the main things that we worry about are falciparum and vivax. Within the African continent, most countries aren't worried about vivax right now, because falciparum is by far much more likely to be what is, unfortunately killing young children and causing significant morbidity. But the further you get along that kind of elimination continuum, then you start to think about vivax, then you start to think about some of the other, Knowlesi and ovale. Great question. That was next time I see a partial hand from you. Okay. So we've actually talked a little bit about this. So this was a good segue. But what are we actually doing with these, what we said, $755 million? How are we trying to reduce deaths? How are we trying to reduce illness and accelerate towards elimination? The bread and butter of President's Malaria Initiative is scaling up interventions that work. We are not going to be the super upstream donors. You start to see entities like NIH, Gates Foundation, Medical Research Council of the UK investing in those spaces. We really came into prominence because there were interventions we knew worked, but people did not have access to them. So we talked a little bit from a vector control perspective about mosquito nets and indoor residual spraying. So again, we're giving you a net to sleep under, so that way, it's providing personal protection for you because the mosquito can't get to you, but it's also providing some community protection because the insecticide that's on the net, we're also spraying homes. So that way, as the mosquito, it might bite you, but as it goes to lay on the wall, rest on your wall, it will then die. So we've, since the start of PMI, provided nets to about 500 million, distribute about 500 million nets. protected about 310 million people through indoor residual spraying. We also talked a little bit earlier about seasonal malaria chemo prevention, so giving those 6 to 59-month-old children malaria chemo prevention. We've protected 23 million children through that. We also give pregnant women chemo prevention. Why are we worried about young children and pregnant women? Why don't we do it for everybody? Anybody online? If you're able to unmute yourself. Why these two groups?
Are they the most vulnerable to like having the most severe illness?
Yep. We see by far the highest morbidity and mortality in young children and in pregnant women. So depending on where you are on that continent, so for example, where I was working in Mozambique, the number of infected bites that individuals would get, people would have 6 cases of malaria a year. The more you have exposure, the more you start to develop immunity, you'll be less likely to have acute morbidity or mortality. Doesn't mean that it's not affecting, for example, your school performance. It does. We have actually great data showing how important being malaria free can be, for example, in terms of school performance, but you're not going to die from it, or you're much less likely to die from it. But then you become pregnant. You actually lose some of that immunity in your first pregnancy. You can have placental malaria. So that's why pregnant women are also really important. They also are more likely to have morbidity and mortality themselves, but also we specifically target them because a healthy mom, what's a healthy mom mean? Healthy moms are healthy babies, right? We want to get her a bed net. We don't want her to have malaria because the healthier she is, one, that little baby when it's born, it's sleeping with mom under that bed net, but it also is more likely to have good protection from mom. So lastly, in terms of the kind of the commodities that we're buying, and I actually can't see my own slide there, is a lot of investments in terms of malaria testing and treatment. So over 600 million tests that are bought, over 700 million treatments that are bought. Every single one of those treatments, that's saving someone's life potentially. So that's a really important area of our investment. But obviously, you can't do any of this in isolation. You can't just hand out tests and treatment as the US government. Everything we do is through the ministries of health. We have extensive partners that we work with, but really what we are trying to do is bolster what ministries of health are able to do. So we do a lot of things like training of healthcare workers because we are not doing it ourselves. We put commodities into national systems usually. And so you show up at rural health facility of Mozambique, you will find a test and treatment there. And odds are that test or treatment was bought either by the US government through PMI or through the Global Fund, often with PMI or US government support. Realizing that. I think I'm okay for time. So in terms, it's not just that, we also have a number of different cross-cutting investments. So for example, we invest in the supply chain. You can't just buy it and have it go to the capital city, right? Somehow, all of this needs to get to the most rural populations. We also, it's not enough to just give you a net. You need to know how to use the net. You need to know why you should use the net and how to use the net. And so we do extensive investments in social and behavior change activities. We also need to understand how malaria transmission is happening. We want to know, for example, periodically, what's the prevalence of malaria in different parts of the country? How many people are showing up at the health facility with malaria? These are critical data for informing our work, which I'll talk a little bit more about later. And so we heavily invest in surveillance, monitoring, and evaluation, and do some support for operations research. So really helping us to understand what's the most effective way to intervene. Are the interventions that we're doing actually having the effect that we expect them to? I won't go in detail here, but this shows just really briefly kind of what that breakdown of, the investments are. And you can see the vast majority of it really does go for commodities. So buying those tests, buying those treatments, nets, indoor residual spraying. So that's all nice, but what do we actually do, right? This was meant to be what can you do with a global health career? So when I was in Mozambique, it was called the CDC Resident Advisor for President's Malaria Initiative. Every country of those 27 has within them a team that includes a USAID Resident Advisor and a CDC Resident Advisor Those two individuals work with a team of anywhere from 1 to about 5 additional USAID staff. And kind of the bulk of what they're doing is helping to make decisions about, well, how do we most strategically use our resources? How do we most strategically support the Ministry of Health? And how can that be complementary to other donor support like Global Fund support? We also provide a lot of oversight of the different institutions that we fund. There are a whole host of different nonprofit and for-profit institutions that are US government implementing partners. You've probably heard of a lot of them, so I won't go into detail, but pretty much every group you've ever heard of that sits in Washington, DC typically is getting a lot of different US government funding. We provide critical oversight to help think about what are they actually doing with that funding. And then we work really closely with the Ministry of Health. So I'm now going to go into a little bit more of a specific example of what I did when I was with PMI. So no judgment here. Some of you were probably wondering where Mozambique is. Here it is, an African continent. Now, fun fact for you is that the east coast of Mozambique is as long as the east coast of the United States. The capital city is at the very, very southern part of the country. Now imagine the United States, but actually take out the vast majority of our functional roads. Now you have Mozambique. So it's an interesting environment in which to try and accomplish anything, but a truly wonderful country that has about 32 million people. And at any given point, over 1/3 of the children have malaria. So for example, in 2018, we did a malaria indicator survey testing children under 5 years old, and 39% of them had malaria at that time. About 60% of the population access care through the public health sector. A lot of the population is very remote. And so community health workers are incredibly important, along with other primary healthcare interventions. Despite that, we're doing pretty well. 82% of the households now have a bed net. 69% of children under 5 years old who had fever in the past 2 weeks actually were able to go and seek care. That's not what it looked like 20 years ago. So despite all of that, there were 10 million cases of malaria in 2021. So you can see on the left, this is the incidence in the country. Now this is estimated incidence. I'm not going to go into detail on the methods on how it's estimated, but you can see in blue where there is an incidence of less than 100 per 1,000. And then you can see in red where there's an incidence of greater than 500 cases per 1,000. What do you see?
A lot of red.
A lot of red. Is everywhere red?
Did you say the capital was done?
Capital's down south, looking pretty good in the capital, right? We're getting towards elimination. So incredibly heterogeneous transmission of malaria in this country. Actually, the same can be said for many parts of the African continent. What you can see in the middle, so that was just in the community. What would we expect is the malaria incidence? The middle is care seeking, so confirmed cases. Do they perfectly align? No, right? For some reason, we're actually seeing pretty good care seeking. For example, this part little right here doesn't look so bad. They're seeking care. We have parts of the country where actually, look, if you just went based off of your routine data, there's hardly any malaria up here, right? Not everyone has the same access to services. So that's one of the limitations of when we decide to only use, for example, the routinely collected data from health facilities. That's affected by who actually has access to those health facilities. And so what we do is we tend to use these data from health facilities, but we do surveys as well that help us at a community level understand what malaria prevalence looks like. And you can see here that there are parts of the country. So this up in the top right is Cabo Delgado, 68% prevalence. 2 out of 3 children had malaria at the time of survey. And that ranges all the way down to Maputo, where you can see it's about 1%. So you are now the Mozambique PMI team. Where do you put your money? That's what we do. Every year, we all come together And we try and make decisions with the Ministry of Health and with our global partners as to what should we invest in where. There's not a right answer. I won't make you answer that, but these are some of the sorts of questions that we grapple with, especially from a donor perspective in global health, but also even just from a Ministry of Health. How are you trying to balance the needs? Actually, it's really important to eliminate malaria in your capital city. It has tremendous economic opportunities, economic implications if you can eliminate malaria. But you eliminate malaria there at the expense of Cabo Delgado. So these are some of the sorts of things that we would have to grapple with. This is just a quick snapshot of, for example, what we did in Mozambique while I was there. And you can see in dark blue the places in which we really concentrated our resources. They look a lot like the highest burden areas, right? Because our overall perspective, and there's not a right or wrong answer, was that right now the most important thing is trying to drive down morbidity and mortality where it's highest. And so that's where you can see we really concentrated our resources, including shown in green and yellow are the places where we did what is really the most expensive intervention we were doing at the time in Mozambique, which is indoor residual spraying. You can also, there's some interest in the vector. You can see in blue and red, the different places where we support entomological surveillance. It's really important to understand the vector, to understand what sort of interventions you might want to do. And so this is just showing you, for example, the places where we did that sort of surveillance. So that's what I was doing in Mozambique, was trying to answer impossible questions and do it as strategically as we could. And then now that I've come back and joined our headquarters team, my main role is that I lead our malaria vaccine team. There's a brand new, recently approved malaria vaccine, first ever. And so that is the main part of my portfolio, is leading that within the US government. But I also am a member of our case management and community health teams. Any of this is of interest to you, I'm happy to have chats afterwards, but that's not at all what I'm really talking about today. I also am on our operations research committee, and then I'm our lead for a number of different new interventions that are under development right now, like, for example, the use of ivermectin. I also support our Kenya and Cambodia teams, which is why you're getting little Kenya things, is that I was in Kenya last week, which means that each time Kenya and Cambodia are trying to come together and make the decision about resource allocation, I'm flying out and joining those conversations to support our in-country teams. I'm going to go really quickly through this last piece, which is a concrete example as to one of the areas that I lead, which is related to subnational stratification and tailoring. So, no one has ever heard of subnational stratification and tailoring. I hadn't, not that long ago. There are still plenty of people within the malaria community that we are explaining this to. But I think you'll find that these concepts resonate, especially based off of what we've been talking about today. So, subnational stratification and tailoring, I'll go into what that specifically is on the next slide. But it is critical, because what have we seen? Was malaria the same in every part of Mozambique? No. It varies temporally. So it might be that this year, this area is looking better than it did next year. Maybe there's going to be a drought there. Actually, there's going to be hardly any malaria. The next year, there's floods. We're going to see malaria increase in that area. Malaria varies over time. It varies over geography. And it varies for a lot of different reasons, including climatic and ecological factors. So, for example, temperature, rainfall, etc. It also varies because we're human, right? There's a critical human factor in there. Maybe we decided to distribute bed nets in this area. We're going to hope that we'll see malaria cases go down. Maybe there's a new person in the community who's really led to a lot of rumors and issues related to indoor residual spraying. So all of a sudden, people all are refusing, and you can't spray any home in this community. There's a critical human aspect, which is influencing malaria transmission. It also has a lot to do with health systems performance. So if you have more community health workers, you start to have more malaria cases, actually. It's a good thing, right? We want those malaria cases. But where you'll see transmission and what level of kind of morbidity and mortality you'll have has a lot to do with how well the health system is functioning. And then lastly, Cabo Delgado is an area that's had conflict. We've had millions and millions of people leave Cabo Delgado, because of some very severe conflict. Population movement has tremendous implications as well. We do not have a ton of malaria transmission in certain parts of Cabo Delgado now because we do not have very many people there. All of a sudden, they're in Nampula. Nampula is looking a lot worse. So there are a lot of different reasons why malaria is looking different, and many other diseases are looking different based off of time and place. And for that reason, you can't just do the same thing everywhere all the time. You have to think about what are your data telling you would be the most effective assortment of interventions. We also, as I mentioned, have a lot of different malaria interventions, including now this malaria vaccine. None of them are perfect. We have to balance and figure out what the most cost-effective way is to deploy what are sometimes very expensive interventions. And then we also need to think about what we put along with each other. You can't just do case management. We do case management, we do vector control, we do chemoprevention, and the way in which those interventions relate to one another are also important to consider. So for that reason, there's been a global push for some national stratification and tailoring. So you can see this was just that map we saw in Mozambique showing the heterogeneity of transmission. So when I say subnational stratification and tailoring, stratification is the way in which we start to geographically and temporally classify malaria risk. So saying this is different than this, and this is different over time. And we end up with different strata of risk. We then, once we've defined the strata of risk, think about, well, what interventions would be most effective? And the kind of core concept is that it's not one size fits all. You really have to use local data and local context to think about what interventions could be most effective. I'm going to go really briefly just to allow time. So this is an example actually from Ghana. What you can see on the far left are confirmed cases in Ghana. But we said earlier, right? Confirmed cases are influenced by a lot of different things, including whether or not people are seeking care, whether or not they're reporting into the health system, and then also what testing is looking like. So one of the first steps that we need to do is think about how do we take our crude health facility data and adjust it based off of survey data to help us truly understand what transmission looks like in this area. Is that enough? We've done some interventions, right? So even if we show over here that this is dark red and that's pink, it could be that in that pink area, we've been doing all of our interventions. If we stop tomorrow, that's going to become dark red. So it's not enough to think about what transmission is looking like. We also want to understand what have we been doing already. So in subnational stratification and tailoring, what we do is we adjust our incidence to try and really get to an understanding of what transmission looks like. And then we also think about where have we already been deploying interventions. So you can see, for example, in green here on the top left, these are the parts of the country in Ghana that already had indoor residual spraying. So as we think about what we need to do in the future, we need to think about, well, what is our incidence? What do those strata look like? But also, what have we been doing already? Because if we stopped everything today, we actually would probably have quite a different incidence. We use that to get together and say, this is what, if we do nothing else, we expect malaria transmission to look like in Ghana. We then use super complex modeling that I do not do at all, but we work with a number of different colleagues from the various academic institutions to actually model out and think about what is the appropriate balance of interventions that get us the most effective mix of interventions. That's what you see in this optimized scenario. So resource agnostic, we would be doing so many different things in the country of Ghana. But then we have to get to a realistic scenario in which we actually have limited funding. So then we start to include cost as we think about effectiveness. And so the goal of subnational stratification and tailoring is to help countries use data to strategically think about what interventions they should do where, and have realistic expectations as to what they can accomplish with that intervention mix. So you can see, for example, here, Shown in dark blue are the parts of the country that would have case. So the entire country has case management. The entire country is doing chemo prevention for pregnant women. But then you start to see differences in terms of what sort of nets they're getting, when they're getting nets. Are they getting chemo prevention for children? Are they getting residual spraying? So this is just one example of an area of work that I'm involved with, which is really helping countries to better utilize their own data to more strategically deploy resources. Because is funding going up? No. We have to figure out how to more effectively deploy the limited resources that we have. So I won't go through this, but it really is a process for helping us to answer a number of different questions, such as, what do we do where, and how do we transition from one to another? So it's a modeling process, but it's really has to be owned by countries using their own data to answer the questions that they grapple with each time they're sitting down to write, for example, a global fund funding application, or to help inform what goes into PMI funding. So what do? I kind of at a global level am kind of leading coordination between a number of different stakeholders like WHO, Global Fund, the Gates Foundation, modeling groups and ministries of health. So that way we have some sort of coordination amongst the way in which we're supporting ministries of health around this. I develop guidance for our in-country PMI teams in terms of what they should do, how they can kind of effectively engage, but also how to make sure that this kind of high-level process isn't totally disconnected from the reality of their countries. That's a really critical part and priority for us at PMI. I also provide kind of regular updates to our PMI leadership about some national stratification and tailoring, and then I directly support teams. So last week when I was in Kenya, I was there because the country is starting to embark on some national stratification and tailoring, and I was there helping it to be as useful of a process as possible. So in a nutshell, this is kind of one global health career, one way I think in which we, in one specific area, malaria, but I don't think unique to malaria, are trying to balance using data as much as possible with resource envelopes that are not commensurate with need. So thank you for your time. I'm happy to talk about any of these other things at some point, but hopefully, if nothing else, you have left this with one idea as to what you can do with a global health degree. I know we've had a lot of questions kind of as I was going, but I'm happy to answer anything. And I'm seeing things in the chat. Should I? Patrick, do you want me to click on here and see what's?
If you can, I
Oh,
know.
looks like some things. I'll take questions too, though.
Does anybody have any questions?
What is malaria treatment like? Like, what's the duration of treatment? And then do people need to take their medicine if they're taking medicine with like food? And then do they have access to food?
Great questions. So falciparum treatment, so at this point we use artemisinin containing treatment. So a lot of different drugs out there, they all include one key ingredient, artemisinin. The main ones that are in use, for example, artemisinin lumefantrine is the most prominent within the African continent. It's 3 days of treatment. You're taking it twice a day, but you are, in theory, supposed to take it with food. That is absolutely an issue. Not everyone has food, obviously. And so it's also trying, that's part of the SBC, the social and behavior change communication that we have for providers. What do you tell a patient when you hand them a treatment that they don't have any food to take it with? If anyone's a mom in here, have you ever tried to give your infant a treatment that doesn't taste great? I have vivid memories of my daughter just spitting prophylaxis all over. So there's a lot of different things in terms of understanding both from patients, but also from providers related to that. Vivax is a lot more complex. I can send you some info about it if you want, but Vivax, there are some screenings that you have to do in advance, and depending on what that shows, it can either be a 7-day treatment or far longer treatment. So we're okay over here.
We're still online. They want me to do updates.
Okay,
You're
no,
good.
it's fine over here at least. So barriers to the malaria vaccination program you've come across. So the malaria vaccine was only finally WHO recommended about a year ago. So it was in December of 2021 that we had the first WHO approved malaria vaccine. In advance of that had been a large scale pilot, which occurred in Malawi, Ghana, and Kenya. So we have at that point, we had 3 years of kind of large scale large scale subnational implementation of the malaria vaccine. Those data actually are what informed the WHO recommendation. So in terms of common barriers, there's a lot of different misconceptions. One of the biggest barriers is that this is a 4-dose regimen. Depending on the country, it usually what we're starting to see in broader deployment is that it is at 6, 7, and 9 months, and then 24 months. That is late. That is the latest in a routine EPI program, so routine expanded program on immunization. Oftentimes, these are countries where by the time they have a 24-month-old, she's pregnant again. She's got other work that she's doing. It is very hard to get mom in within, at this point, not a very small baby. So the schedule itself is an issue because we just don't have great second year of life platforms. Now, the EPI programs, the immunization programs have been quite excited by the malaria vaccine because we want to keep having moms coming in for vitamin A, for well baby, for nutritional visits, etc. But that's absolutely a challenge. We also have had all of this in the face of COVID, right? These same healthcare workers that are trying to give the COVID vaccinations are also trying to give a whole battery of other vaccines as well. It's also not a perfect vaccine. We all were disappointed, at 80% effectiveness. This is a 39% effective vaccine and has waning effectiveness. It's also the most expensive vaccine that's ever been incorporated into routine immunization. We also don't have enough of it. So we have 18 million doses over 3 years that are going to be deployed in starting next year. Need could be as, depending about 80 to 100 million doses a year. So no shortage of problems, which makes it an interesting team to be highly involved in. But it is a really critical first vaccine. We look, and so we're looking at this as establishing a platform that as we get a better vaccine, as we get better supply, we'll be able to build off of what we're starting now. So we've actually just this past month had 13 countries submit their first applications for the malaria vaccine, and we've just gone through a review process for that. So we'll begin having new vaccine deployment as early as January of next year. So, okay. Sure, Steffi. Okay. What role does agricultural development, economics, and labor immigration have in malaria transmission? I feel like we could have an hour conversation about that, but I will just kind of briefly say, first off, economics is central, right? Economics has a lot to do with what sort of housing people live in, has a lot to do with whether or not that family is able to access treatment, to access care. Economics is, I think, a linchpin in everything that we do, particularly related to malaria. Agricultural development is a huge issue. Rwanda was making a lot of important progress in terms of malaria transmission. Then they started a really fantastic agricultural program that led to a lot more stagnant water, and then we saw a lot more malaria transmission. There's a very close link between malaria and what is happening in terms of local agriculture, local development overall. And so and unfortunately, the work is often quite siloed. And so we don't have that kind of cross-sectoral collaboration that is really critical. Labor immigration, a good example of why this is important. I guess summary answer is it is important. But for example, Cambodia is one of the countries where I'm working. Cambodia is hoping to eliminate malaria by 2025. It's a nice aspirational goal at this point. It didn't feel so aspirational not that long ago, but there's a lot of work to be done. But the last people who really are having ongoing malaria transmission are forest goers. They go into the forest, they're, have a number of different economic, things that they're doing in the forest, including, cutting down of forest, and that's a part of their important livelihoods. They're also getting infected by malaria there. They come back to their communities. You have ongoing malaria transmission. So actually, most of what we are doing in the greater Mekong region, especially as it relates to elimination related activities, are trying to effectively target those forest goers, giving them chemo prevention when we can before they go into the forest. We're making sure we're testing and treating them as they're leaving the forest. So just to say, the role is large, and it's, I think, something that we continue to try and dialogue more around, but there's a lot of important ongoing conversations that certainly have to happen within countries, but I think also as a global community. So I think that was, yeah.
Thanks. Could you speak to like PMI's investment in like health information technology and how like the digital health space, and what's that looking like in like Mozambique or other African countries or other contexts, kind of like thinking about like the missing surveillance data and resource allocation, and what are some of those conversations looking like? And then I guess the part two are like lessons between different countries and thinking about like rural contexts under kind of like generalized lessons.
Yeah, absolutely. It's a great question. So digitization has been a really important, I think, global health conversation for a number of years. And I think there are a lot of important experiences, including from PEPFAR and others. As it relates to malaria in particular, there are a couple different ways in which we are talking about digital health. So part of it is through community health workers. So depending on the setting, these community health workers' data are not necessarily folding into national data, or they're not folding in at a kind of with a timeliness or with a level of granularity that would be relevant for decision making. So knowing, for example, that Elizabeth is a community health worker, she's seeing X cases and she needs Y treatments, we don't usually have those sorts of data. So there's been a big push, depending on the setting, to think about how we can help community health workers to access digital tools, some of which are oriented towards supervision, but some of which are much more oriented towards really just the HMIS side of it, of feeding those data in a way that can also link to the extent possible with commodity response. We also have a lot of ongoing conversations related to campaign digitization. So I mentioned these indoor residual spraying campaigns where we are going house to house to house to give people malaria, or to give spray insecticide on walls. Usually those data are historically coming in paper-based. They're not being, somebody's sitting there in a data warehouse that's typing it all up. If it's a PMI supported project, lots of times those data go nowhere. There's a push towards having as much as possible campaign digitization, especially because that same house where we go and do spraying with insecticide, we'll come back a month later and do chemo prevention. 6 months later, they're coming and doing a big NTD campaign a year later. So there is a lot of talk about how can we start to have better, in particular, denominator data through digitization of community level campaigns. And then another kind of critical piece is, as you start to think about malaria elimination, you start to need to think, instead of at the aggregate level of 1,000 cases, you start to really need to understand each one of your cases. Did they come from that forest? Did they get it in their local community? And so as you move towards a case-based surveillance approach, there's also kind of a need for greater granularity and response. So one of the big successes that you see within a lot of the greater Mekong subregion is related to 137, which is essentially the time from reporting to awareness to response. That has to be fast if you're trying to eliminate malaria. And so then you start to need things like digital tools. So just to say, there's a lot of different ways in which people are thinking about it, and some conversations that are happening across different health areas. But I think it's also been a balancing act that you find some poor community health workers that have 5 different phones because they actually have 5 different roles. And how do you make sure that they're not reporting in silos for each of their different interventions? And how can we make sure that this is actually facilitating their work instead of impeding it? And I think those are some of the important questions that are under discussion as it relates to digital health.
Well, thank you, Rose. That was excellent.
Thanks.
Thank you.
Rose.
Yeah.
Just want to introduce myself.
Yeah.
Say hi. Thanks for the opportunity.
Yeah.
And thanks for the presentation. That was really awesome.
Sorry, what was her name?
My name's
Good
Julie.
question.
Julie.
It's pretty fine. That's usually I'm like, my background's in wildlife.
No, good.
That's what I'm interested in. Malaria.
Yeah, for sure.
We should just write that, like my favorite, a lot of that one. So I should offer it.
Yeah.
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 Exactly. And I'd love to talk to you more about. I'm gonna keep that on this semester. I'm gonna be great. Yeah.
My email.
Yeah.
Okay.
And did you share?
I don't think I did.
Not run with.
I'll do it.
Yeah.
Are you putting up to your?
No, I don't.
Mark.
That goes out normally with that
Thank you.
flyer.
Yeah, so it's R and then my last name is Zulliger, ZULLIGER.
Sorry, CULL.
Yeah, it's not that Gmail.
What year are you?
Are you here in town?
It says in the senior on cyber. No.
Okay, great.
Yeah.
That would be.
That's cool.
Yeah.
We need more undergrads to show up for things like this.
Really interested
Yeah.
in